Hello, I'm Dr. Tom Schuler, Chairman of the Medical and Scientific Board of the National Spine Health Foundation. We are here to provide you with knowledge and an education how to overcome your spinal problems. We provide unparalleled access to the world's best experts. Here at Spine Talks, we welcome you and want to help you live a better life. Welcome to Spine Talks. We are here to talk to you about cervical disc replacement. That's a disc replacement in the neck. We're going to have our panel of experts. We're bringing to you the world's best to give you unparalleled access to healthcare. The National Spine Health Foundation is happy to host this webinar to help you as patients understand what options exist for you, what may be able to help you get back to your life. Today, we're talking with three experts, members of our medical and scientific board, and we're going to discuss what a cervical disc replacement is and what you can think about in terms of why you would have one or why your surgeon would choose to do one on you. I am Dr. Thomas Schuler. I am the chairman of the medical and scientific board of the National Spine Health Foundation. I'm CEO of the Virginia Spine Institute, and I've been in practice about 30 years. I have vast experience with artificial discs. In fact, I've got some in my neck. So I'm somewhat of an expert on this. With that, I'd like to give Frank Phillips from Chicago a chance to introduce himself.
Well, thanks, Tom, and it's a pleasure to be with you all today. My name is Frank Phillips. I'm a director and professor of spine surgery at Rush University Medical Center in Chicago. Like Tom, I've been a spine surgeon in practice for more than 25 years. Been very involved in artificial disc replacement, particularly in the cervical spine from really the get-go. Have participated in a number of FDA studies that led to the approval of these devices, and I frequently use them in my everyday clinical practice.
Thank you, Frank. Coming to us from Atlanta, Georgia is Paul Jeffords.
It's a pleasure to be here. My name is Paul Jeffords. I'm a spine surgeon in Atlanta, Georgia. I've been in practice for about 16 years. I was fortunate enough to do my fellowship training at the Texas Back Institute, where they do a lot of artificial disc replacement, and we're involved in a lot of the FDA IDE trials. So I had a lot of experience during that time, and I'm just happy to be here and add my 2 cents.
Dr. Christopher Good.
I really would like to thank the Spinal Health Foundation for putting this together and for having me be involved. I'm Christopher Good. I'm a spine surgeon. I'm the president at the Virginia Spine Institute in Reston, Virginia. Routinely using disc replacements both in the low back and in the neck. We have served on FDA studies on multiple lumbar and cervical disc replacements over the years, and I've acted as a site investigator on multiple different cervical IDE studies.
So let's start the conversation. When we're talking about disc replacements, we have to understand what a disc is. So Paul, can you help us understand, help the patients understand, what is a disc?
Sure. So if you think about the spinal column, the spine consists of individual bones that we call vertebrae that are stacked one on top of the other, sort of like building blocks. In between each of those bones, there is a cushion or a shock absorber that is called the disc. And the disc consists of 2 parts. There's an outer wall, which is called the annulus, which is basically tough fibers that are woven together. And then there's a softer middle portion on the inside that is called the nucleus, that is like a firm gel that forms more of the cushion for the disc.
So Frank, building on that, we talk about an artificial disc. So what is an artificial disc, and how does that compare to a normal disc?
Yeah, so an artificial disc is essentially a device that attempts to replace the natural disc that Paul just described. Historically, when we treated cervical problems, and I'm sure we'll get into diagnosis and conditions, we would often fuse the spine, which essentially means knit the bones together. What an artificial disc attempts to do is place a device between the vertebra, between the bones, and replace the disc that we've removed at the time of surgery. So there are various designs of these discs that are commercialized. Many have different features. Some more closely replicate a normal disc than others. But the goal of all of these is to restore motion and ideally try and mimic the normal motion that a disc with a complex structure Paul outlined allows our spines to have.
So Chris, you talk about maintaining motion. Why do we want to maintain motion?
The human body is meant to move, and preserving that motion whenever we can is inherently beneficial. And so if we think of our spine with these bones and discs stacked one on top of another, they're all moving in relation to each other, kind of like cars on a roller coaster. And as we go through life, depending on our genetics and luck and other factors, the discs or the joints of the roller coaster can start to develop issues. And so a fusion is essentially taking those two cars on the roller coaster and welding them together. And while there are many times that is a great thing to do for someone, the sacrifice is it takes away the motion at that level. And at one level, there's obviously a different sacrifice than if that needs to be done at multiple levels. By using disc replacements, we're trying to keep someone functioning like a roller coaster rather than turning them into an 18-wheeler over time.
Motion is good. Fusions take away motion. Does that mean fusions are bad, Paul?
Oh, absolutely not. So a fusion is still a tool that we often use that in many, many cases provides patients significant relief of chronic pain. So, for every, 100 patients that come into my office that need spinal surgery, whether it's a reconstructive type of surgery, a very small percentage of those patients are candidates for disc replacement for various reasons, which I'm sure we'll get into. But fusion is still a technique that we use very commonly and very frequently with much success.
Frank, if we're talking about the fusion versus a disc replacement, what would make you choose one over the other for a patient?
It's a great question, and one as clinicians we wrestle with. We are fortunate that the studies that have been performed over the years and the FDA studies that are probably some of the best studies ever done in the history of spine surgery, what we call level 1 evidence, which is very hard to come by, really helps us define the fairly narrow indications for disc replacement compared to perhaps somewhat broader indications for fusion, as Paul was talking about. So the way I think about it is, many times patients have very advanced disc degeneration. So over years, wear and tear, they get what's called arthritis in the disc, and the disc wears out. And essentially, you get bone rubbing on bone with big bone spurs that develop around the disc. And the disc really doesn't move at all. And probably by the time you see your doctor with symptoms, it probably hasn't moved for 10 years. So in that patient, it makes little sense to try and force the disc to move in a way that it hasn't for years and years, and believe we've really done the patient a service. So that, for me, a patient with very advanced wear and tear of the disc and immobile disc is not an ideal candidate. So the real candidates are patients that are earlier on in what we call the degenerative cascade. So patients that have a relatively functional disc, it moves, they haven't completely worn out the disc, but they'll often have a herniated disc, which I'm sure we'll talk about, or a bone spur that's pinching on the nerve that needs to be cleaned out and the pressure removed off the nerve. So those types of patients with a relatively functional disc that's not bone on bone, end stage degeneration in my practice are sort of the ideal patients that we think about doing a disc replacement on.
When I look at the spine, I look at it as a 3-joint complex. You've got the disc in the front, and then there's 2 little joints in the back that are called facet joints. And these are little joints that allow the spine to hinge and move. And so for me, in choosing somebody to have a disc replacement or not, we have to make sure we look at not just the disc, but also the 2 joints in the back. And I think that's a common reason many times people won't be a candidate for an artificial disc, is that the disc in the front may benefit from an artificial disc, but if those little joints in the back are very arthritic and degenerative, then that kind of hurts it too. So that's another reason that may affect it. And Chris, did you want to add anything to that?
My bias is to try and preserve motion whenever it's the right thing to do, but it is possible for a disc or a level to be too far gone. I do think that we always struggle between this desire to maintain motion, which we think is inherently good. And we also think that maintaining motion at a level that needs surgery is actually beneficial for the disc around that level, basically protecting the rest of your spine down the road. But there are certain times when, as Dr. Phillips alluded to, it's just degenerated, it's too far gone. And so if the treads of your tire are back on the interstate behind you, getting out the fix-a-flat is no longer an option. And so we're trying to make this balance between doing the smallest surgery, preserving motion, but we have to make sure we're actually getting a good cure for the patient at the same time, and trying to balance disc replacement versus fusion, and sometimes even using them in concert with each other.
Do you ever combine artificial disc and fusion? And if so, can you explain what that means?
That's what you alluded to earlier, what we call a hybrid procedure. So for instance, Chris was just talking about the fact that some discs are too far gone. And in many cases, patients come in with more than one disc involved. And what I often see is you'll have one disc that is severely degenerated with large bone spurs and severe nerve compression. And the disc above that is moderately degenerated. There's some nerve compression, definitely causing some symptoms. And so the question is, well, do you fuse both discs, or do you put artificial discs in both discs? And that severely degenerated disc may be too far gone for a disc replacement. So in that case, we might fuse that disc, but preserve the motion, let's say at the disc above that, and put an artificial disc in above that. And that's one surgery. We do it simultaneously. But basically you're doing a hybrid between the fusion and the disc replacement.
That's actually something that I've had done, and my surgeon, Dr. Good, can comment as to why he decided to do that on me.
I did that because Tom told me to. But in all seriousness, many people, between genetics and wear and tear, it's more than one disc that's involved. And as spine surgeons, we do very physical work, and we put our necks in bad positions. And so by the time Dr. Schuler came to needing surgery, it was actually multiple discs in his neck that were affected. And a situation where fusing multiple discs together and stiffening the spine in that way really does raise some concerns about his ability to keep this last decade of his career going. And so in his situation, there was one level that was too far gone. No question about it. And so we removed and fused that disc. But in the adjacent disc, the next disc, we're able to go ahead and remove that disc and do a replacement. And by preserving that motion in Dr. Schuler's spine, able to keep his neck functioning better, extending his career. And so we're able to use this hybrid concept, basically treating each disc with what treatment is best at that given level, rather than a cookie cutter approach of just fusing or replacing all the discs.
We sometimes hear about what insurance companies let us do and not. And so, Dr. Phillips, if you can comment a little bit about what is a off-label use and how does that impact physicians' ability to do what's in the best interest of the patients?
Yeah, so that's a really challenging question, Tom, and it's one I think all of us on this Zoom wrestle with probably every day in our practices. We're trying to do the right thing for our patients, and often our hands are tied by forces outside of what we do as doctors that don't have the patient's best interest necessarily in mind. So technically what off-label means is that the FDA defines the clinical indications for a procedure. And often that's based on the company that's, for example, in this case, developing an artificial disc, does a study and has specific indications that are studied. And to get the study done, we usually need fairly narrow indications, because you've got to get specific patients enrolled, tight group of patients to prove that the disc works. So at the end of all of that, you go through the FDA panel, they review all the data, the complications, the good results, the bad results, and they approve or don't approve it. If they end up approving it, it's approved for specific label, for specific indications, which is the labeling. It's like what medicines have when you open a package of pills, is the paper insert nobody reads that actually has the labeling of what that medicine in that case is indicated for. So the problem with all of that is at the end you get FDA approval for fairly narrow indications, and it's labeled for those uses. And the insurance companies, who, let's be honest, frequently don't want to pay for newer technologies, jump on that, and that's all they'll reimburse for. If, for example, in this conversation, there's no studies to date that have been done in the US specifically looking at this hybrid construct. It makes perfect sense. It's perfectly logical. No sound clinical mind would dispute that it's a good situation in the situation Chris just described. But technically, because not being studied in that specific situation, it's not labeled by the FDA for that use, which leads to a lot of problems in terms of getting those procedures approved, even though I think all four of us on this call would agree many times it's the obvious, logical, medically correct choice. So it's a complicated issue, and hopefully I didn't get too into the weeds, but that's really the way sort of I think of on-label and off-label use. And again, off-label is how the FDA labels a product. It does not dictate best clinical practice at all.
When a company wants to do an implant test to get it approved by the FDA, they have to set up a whole research protocol, and that's very specific. It'll be for a 1-level case or a 2-level case, and it costs a lot of money to do these studies. So many times, while an artificial disc would work great at multiple levels, 3 levels, 4 levels, whatever, it only got tested at 1 and 2. So that label that's approved by the FDA is 1 and 2. And insurance companies hide behind this concept that since the FDA didn't approve a 3-level, they call it experimental. And at the end of the day, it may be what's in the best interest for the patient, but it's not approved by the FDA. Now, that FDA does not govern what physicians do, but it governs how companies can market a device. And so the ability of a company to market the device is limited to what their FDA approval is, but it does not change what physicians can do. So physicians can do multiple levels if that's what's in the best interest of the patient. The question is who's going to pay for it and how does it get paid for? So with that concept, Paul, I'd like to ask you, in Atlanta, are you able to do multi-level cases beyond 2 levels if that's what the patient needs?
I personally have not had success in getting for instance, 3-level disc replacement approved here in Georgia. 2-level, usually not a problem. Most insurance companies now are covering 2-level cervical disc replacement, but 3 levels or more, I personally have not had success.
And that's the problem is getting the authorization so that it's affordable to the patient. But I know that I've done 3-level replacements on people, but it's always specific cases where there's a payer that's willing to make that. And the other thing is the hybrids, being able to combine artificial disc and fusion. Again, something most insurance companies aren't willing to do because they claim it's off-label, yet it's often what's in the best interest for the patient. And so it's something that we have to keep an eye on. Does any of the panel want to comment on hybrids or multi-level disc replacements?
I think it's very interesting because the FDA used to provide these indications and then doctors could expand them. So for example, if you're testing a new drug and you test it from people between 30 to 64 years old, a doctor might choose to use that on a 65-year-old, right? And that potentially makes sense. As time has evolved, the companies have started to use these FDA studies to determine who they'll pay for, which is really not what they were meant for. It was meant to figure out if the drug or the device was safe. And so this has transpired over the last 15 years and evolved. And what's interesting is so many things that we did routinely at the beginning of my career and insurance companies paid for and they didn't have a problem are now considered investigational or experimental and therefore not paid for. And so it really is a challenge. When it comes to multi-level disc replacements or hybrid surgeries, it's really very individual for patients, different insurance companies, and I believe it's really different in different areas of the country. So it is something that I try very hard to offer the patient whatever options I think are truly best for them, help them to understand them. And we are able to work through that path and to achieve ways for lots of patients to get hybrids or even more than 2-level disc replacements, although I'd say that's a relatively small number of people who need that and then who actually are able to get that approved. My goal is always to try and help explain that and educate the patient, help them make the right choice medically, and then try and figure out the way that is. And in some cases, we're able to get on the phone and speak with insurance companies and do peer-to-peer authorizations. And by talking about the data and the FDA studies, in some situations, we're able to get them to overturn their decisions for our patients.
All of you gentlemen have been involved in research studies with artificial discs, and we've seen multiple generations come out, different discs. Can you comment? And I'd like each one of you to comment on how do you choose what disc to use, and how do you fit that together with all the different generations out there? And I'll start with you, Frank.
As with most technologies, and we've seen the same with artificial hips and knees, over time these evolve. You usually start with the simplest device, and over time we get smarter and we figure out how we can make them better. So some of the earlier designs, for example, were made out of metal on metal, very sort of what would be considered old-fashioned materials. And we've evolved, and many of the current discs have metal and plastic, much like you see with artificial hips and knees. And then even further, they've evolved to other types of plastics that are even more durable or allow for better imaging on studies that you might need after surgery. So the way I think about it in terms of the design I think the goal of any disc replacement is to as closely as possible mimic the normal motion at that segment. So many of the earlier designs of discs look kind of like putting a hip in your neck. They have a metal and a plastic bearing surface, and they sort of slide relative to one another, which is not how a disc's designed to move. Paul talked about the jelly in the middle and the outer fiber, and that doesn't look anything like a hip. Some of the more recent designs of discs have tried to mimic that more normal physiologic motion. So they have annular nuclear structures. Some of them have different cores in the middle that slide in ways to closely mimic the disc. So the way I think of it, without getting to specific products, is I look for the designs that I think biomechanically most closely mimic the normal disc motion. And it's not just the movement, it's how the disc moves, the pattern of that motion, to hopefully behave as close to a normal disc as we can possibly do. And just, sorry, I know I'm going on, but just to end off, one of the key things about a disc replacement is not just the motion at that level. If you fuse a level, it puts more stress on the next one up, which we're probably going to talk about. So having a very physiologic motion at the artificial disc probably gives you better protection for the next level up from wearing out over time.
Thank you. Paul, you want to answer that?
I think it's a combination of things. I think Frank definitely explained the biomechanical aspects that we all think about when choosing a disc replacement. Obviously, we want to look at the data that's been published and make sure that there's good data. And obviously, for a device to be FDA approved, the data obviously has to be very good. In my hands, it's a lot of experience. Basically, the device that I use, again, not to name names of devices, but the device that I use, I've been using for 16 years, and I'm happy with it. And my patient outcomes are good. And so, why change? So that's part of it too. A lot of it is, what I was trained on, what I've used. But when I, look at new devices that are presented, I look at biomechanics, I look at stability. That's one of the main things I really want to look at is, is the device safe? Is it stable? Am I comfortable that it's going to stay where I put it? And I think those are the primary factors.
Chris?
Yeah, I think we definitely see patients who come in and they've researched and they have one that they want specifically. For me, I've tried to get experience and become educated on all of them to be able to apply whichever one I think is best for any given patient's problem. Now, the reality is a surgeon should use the disc replacement that they're best at, because this is a surgery that requires precise carpentry and it has to be well done for the disc replacements to work. The reality is FDA studies, which have been well done for many of these implants, really do show excellent results. Patients are doing well. And if you compare these patients to people who get fusions, the studies are showing they're doing at least as well, and in many cases better over time. A big one for me is the stability. There are some people where their tissues are very stretchy, people who are double jointed or what we call ligamentous laxity. And if I have somebody with those type of concerns, I really don't want to put in an implant that has more play or more motion in it, because that implant is going to really require the patient's body to take care of that. And so I'm always trying to look at how much stability does this patient need. There are also some different sizes, especially for smaller people. Some of the implants allow a smaller size, which I think has benefit. And so I really am trying to customize all these different things with each of the surgeries that we do.
maintaining motion is a key thing. And the studies you alluded to, people that had a 1-level fusion and had a 1-level artificial disc, outcomes were very similar. But once they got to 2 levels, the 2-level artificial disc did better than the 2-level fusions. They all did well, but the 2-level artificial disc did better. So I think that's just the concept. Preserving motion changes what Dr. Phillips talked about in the stress transfer to that adjacent level. So just by being able to protect the adjacent levels as well as maintaining motion at the affected levels, I think people do better. And that's the data. And that's why ultimately 3-level, 4-level cases will become commonplace. And the question will be, do you really want to do a fusion, or should you be doing an artificial disc? And obviously people that are too far gone may need the fusion, but artificial disc is a great option in the right patients. It all comes down to selection. Patient selection is critical, but the surgeon's skill matters. How does a patient find a surgeon that can do an artificial disc? And how do they know whether that surgeon is the right person for them? So again, Frank?
Like always these days, there's a lot of information on the internet, some of it good, not so good. To be honest, a lot in my practice, and I'm sure the same is true for all of you, a lot of it is sort of word of mouth. So that's often a good indicator of who's a good disc surgeon. I think if you see somebody, you want to have an open conversation. You probably don't want to be the second patient that the surgeon's doing a disc replacement on. You want someone who's got a track record, who's experienced. Often you can ask to speak to prior patients and get a sense for what the experience is like and how they ultimately do and how the recovery goes. So it's a difficult thing to do. And it's not necessarily all spine surgeons do everything and do everything well. There are many surgeons that do very complicated deformity surgery, but very seldom do neck surgery. That's probably not the right surgeon to see for a disc replacement. So I think you want to research your surgeon as best you can, ideally talk to patients and make sure, and most surgeons I think are fairly honest, ask them what their disc replacement experience is like.
Yeah, I think just to piggyback on what Frank said, I think word of mouth is probably by far for me the number one referral source. Obviously asking the surgeon the hard questions, how many of these have you done? What's your success rate? How many of your patients needed revisions? But oftentimes I think patients really ultimately they do the research ahead of time. I mean, most patients that come into the office, they've done the research, they know all about the surgeon they're seeing. And then it's more of a feeling, is there sort of this mutual trust? Have you developed a relationship with that surgeon where you feel comfortable? Because, when you're undergoing surgery, as you know personally, Tom, it's a big deal, and you want to make sure you have that trust with that surgeon so that you're comfortable and confident in the endeavor that you're about to go into.
I tell people, I think you go into surgery, especially a disc replacement, with very high expectations, and you expect you're going to do great. I think you want to make sure the surgeon you're working with is the person that you would work with if there are difficulties or bumps in the road, and you're going to be able to keep working with that person and communicating. And I really think that's important. So most of my patients have already researched the numbers. They've talked to other patients who've worked with me via chat or some kind of local group. And so I think that kind of baseline research is critical. And I think most people are really good at doing that. I would say if you think you need a disc replacement and you're being told no, and that may be the right recommendation for sure, but I do think it makes sense to ask questions as to why and why a fusion may be better, and really try and understand that. Because if the answer is I don't really do disc replacements or something along that line, you really want to get to that information, and that may be a situation where getting more than one opinion, or seeing somebody who really does do disc replacements and hearing the other side of that makes sense before you make a final decision.
We've talked about disc replacements, but let's help the patients understand what actually is the recovery process. Because people are like, oh my God, am I going to be disabled? Am I going to be limited? So Paul, do you want to touch on a
that
little
me
bit
or
on the
him?
recovery from a disc replacement?
I think obviously every surgeon has their own, unique protocols, but I think overall, most of us probably follow somewhat of a similar protocol. For my patients, most of my cervical disc replacements are being done in our outpatient surgery center, which means that they are not spending the night. We have a protocol where we observe the patients for 4 hours at a minimum, and then we send those patients home. They come back the following day for a recheck. I have my patients wear a soft neck brace for 2 weeks. When they go home that first day, they're able to walk, they're able to climb stairs. They don't have to go home and be on strict bed rest. I tell most of my patients that they should be able to go back to driving and back to the office to do desk work starting in about 2 weeks, if not sooner, depending on the situation. Airplane travel, I say at 2 weeks, if you're doing well, you can fly. I personally start my patients in physical therapy 6 weeks after surgery, just to allow some healing and for soft tissue healing and some bone healing. And so at 6 weeks, they start some physical therapy for neck stretching and range of motion. And at 3 months, I let my patients go: golf, tennis, exercise, back to the gym, basically a full active lifestyle at 3 months without restrictions.
Yeah, I mean, my protocol, interestingly, is almost identical to Paul's. I do almost all of them in the surgery center. Patients go home the same day. Yeah, pretty much identical to protocol. I mean, it's actually, most patients, just to give you a sense, are off pain meds within a couple of days. It's really surprisingly not a very painful surgery. One of the advantages of going from the front to the neck, which we typically do for these, is you have to cut through very little muscle. You literally cut through the skin and you kind of dissect down to your spine with the finger. So there's not a lot of disruption. And as a result, not much pain. So most patients are off strong narcotic pain meds if they need them at all within a few days. So very similar to the protocol Paul described. It's not uncommon. I do the same thing where I say sort of 3 months they can go crazy, but I'm sure we all see those patients. When you tell them at 3 months they can do what they want, they go, okay, it's all good, doc. Yeah. Can I tell you the truth? Yeah. I've been playing golf since a month out from the disc replacement. I mean, we hear that all the time. But I do almost exactly the same protocol that Paul described post-op.
Frank, you talked about going from the front of the neck, and I think that's something that always kind of amazes patients. And I know we do the same approach for fusion as for an artificial disc, but why go to the front of the neck?
Yes, I think one of the biggest sort of issues with any type of spine surgery is when we disrupt the important muscles around the spine. Most of the muscles that control our spine, whether it's the cervical or the lumbar, are located in the back or the posterior part of the spine. And anytime we access that spine, we have to violate those muscles. And to some extent, they recover, but likely never fully return to normal. So anytime we can do surgery, whether it's in the lumbar spine or the cervical spine, and go it from the front, where we don't have to disrupt those muscles, I think there's a huge advantage. It helps in terms of long-term outcomes where you don't have muscle damage, which heals with some scarring and maybe some less than normal muscle function forever. And it also impacts the early post-op recovery, where much of the pain from the surgery is from the disruption and the retraction of those important and very big paraspinal muscles that are situated in the back of the spine. Going from the front, as I said, you really don't violate any muscular structures, particularly in the neck. You literally, as I said, you cut through the skin, we do a little bit of gentle dissection, and you're looking at the front of the spine. So I think it's quicker recovery early on, less pain for the patient, and I think long-term, less permanent muscle injury by avoiding going from the back.
Chris, you want to add anything about why to go to the front over the back?
If you look at how the entire field has evolved over the last 15 to 20 years, we're seeing that more and more and more, and trying to avoid surgeries that detach the muscles and avoid posterior surgery completely. If you compare an average person who's had a surgery in the front of the neck versus a surgery in the back of the neck, if you look at the pain they have for their recovery and how fast they get back and pain medicines, I think, we see a very big difference. So the majority of the surgery that we do is in the front of the neck, and people are usually surprised by how well they feel. They wake up and I hear, it's like you took a doll's arm and popped it off and put a new one on, and people are really commonly kind of astounded at how surprisingly good they feel with this approach, especially for 1 or 2 level disc replacements.
I've had my neck operated on from the front and from the back. The front surgery is much easier and better. It's also safer in terms of it doesn't need to manipulate the spinal cord. So we get better alignment, better reduction, but it's actually less painful. So you get a better outcome and it's less painful. Great combination for the patient. We've got some questions submitted online by patients. And so I'm going to read a little scenario here, and I'm interested in each panelist's comment on it. And so the first question is, I'm a 40-year-old runner and oncology nurse. I woke up 3 months ago with sudden onset of left cervical radiculopathy and severe pain. So cervical radiculopathy is pain radiating from the neck down into the arm. And so this person's hurting with severe arm pain. It goes on to say, I had a steroid injection, which helped greatly with the pain, but my left triceps, which is the muscle in the back of the arm, is very weak. And there's severe neuropathy of the middle and index finger. So the 2 long fingers, they're having numbness in that area. There's significant atrophy in my arm and can only hold 2 pounds or more for no longer than 15 seconds. Is surgery necessary? And if so, what's the best disc replacement device to be able to run again and work as a nurse? So, Paul, you want to take a stab at that?
So patients ask all the time, when do I need surgery? Where does that come into play? And I think one of the problems that patients face when they have spinal problems is that there are so many different treatment options out there, from medication to physical therapy to chiropractic treatment, acupuncture, yoga, Pilates, injections, so patients can get confused. And so I try to break down the options into 3 phases. And I say, we know that there's no magic treatment that's going to make that disc go back inside and make the disc normal again. We can't achieve that. That's not the goal. The goal is to get you feeling better. And if you have weakness, to get rid of the weakness. And there are 3 phases of that treatment. Phase 1 is all the non-invasive treatments, which is everything from medication to physical therapy to chiropractic treatment to traction. And we usually try that for about 4 to 6 weeks, unless the patient has dramatic weakness, which it sounds like this patient does. In that case, we might bypass that phase because of the weakness and potentially go to phase 2 or maybe even phase 3. Phase 2, at least in my mind, is steroid injections. And I've had epidural steroid injections in my neck for radiating arm pain. And fortunately, they worked. And I was able to avoid surgery. And patients will often ask that, well, why not just go fix it? Why should I do injections? Well, surgery is the treatment that has the most risk. It's the most invasive treatment. And anytime that we can avoid surgery, we always want to try to avoid surgery, because in my case, I got injections 6 or 7 years ago and still, doing well. So patients can get long-term relief from that. And surgery is what I consider to be kind of the phase 3 of treatment. And I tell patients, look, there are really 2 primary indications for surgery. One is just severe, unrelenting pain that has not responded to any of the other treatments. And the other is neurological deficits, or what we call deficits, but neurological weakness. So in this case, this patient has what it sounds like pretty profound weakness. I would imagine that the MRI scan probably shows a pretty significant size disc herniation and severe nerve compression. So without having seen this patient, in my opinion, yes, it sounds like this patient does need surgery. Assuming that they're a candidate for disc replacement, I think most of us on the panel would probably agree that most of the current FDA-approved cervical disc replacement devices should allow a patient to go back to a very active lifestyle, including running, including, vigorous exercise. So I'm not sure that it really matters which disc is used, as long as that nerve nerve compression is relieved. That's the primary indication for the surgery, is to get the pressure off that nerve.
So Frank, for that patient, the question is surgery necessary? And what would you recommend for the best disc replacement? What's your take on that?
I pretty much agree with everything Paul said in terms of how we think about patients with radiculopathy, which, as he said, is usually a piece of herniated disc pushing on the nerve, giving people very intense arm pain. And typically, if the people come in with pain, you're going to treat them conservatively for a period of time. Much like Paul said, this patient that we're discussing has significant weakness for 3 months, has atrophy, which is the muscle sort of wasting away, which is telling us there's pretty profound pressure on the nerve. So in my mind, I think at 3 months with weakness, and perhaps even a little earlier with such profound weakness, I would be sort of thinking seriously about surgery. Just to be clear, surgery doesn't always guarantee return of the strength. Sometimes there's been enough injury to the nerve, particularly if people wait 6 months, 9 months, a year, where even if you get the disc off, the nerve doesn't improve to the point where the strength comes back to normal. So I think it's important for patients to have the right expectations, that the goal is to return the strength to normal. Getting the pressure off the nerve probably gives you the best opportunity in this situation to do it, but it certainly doesn't guarantee it. And I think it's important to set that expectation right. And it varies. Some people literally wake up, say, wow, I can't believe it, my strength's 90% back to normal. And other people, it's a 6-9 month process for the nerve to slowly regenerate. So I think setting expectations is key. But yeah, this patient, obviously, like Paul said, it would depend what the x-rays, the MRI look like. But if it's what we call a soft herniated disc with that amount of weakness, I mean, I would tell the patient we do the surgery sooner rather than later. It sounds like an ideal candidate on the surface, at least, for a decompression, which basically means taking out the disc that's pushing on the nerve and then reconstructing that with an artificial disc. And much like everybody said, in this type of patient, there's excellent data from FDA studies and subsequent clinical studies showing good results with most of the current artificial disc designs.
We're really blessed with the technology we have today. So Chris, did you want to comment?
So I think all of us on this would agree that many people, in fact, most people who have disc herniations ultimately get better naturally. The body has a tremendous healing ability, and many people get better with time, high-level physical therapy, medicines, as we've discussed. For me, there's always a little bit of a balance between giving the body enough time to heal, but also not waiting so long to consider surgery that you jeopardize your chances of the best success. So if I see someone who's developing significant weakness, symptoms are going on 6 weeks, 8 weeks and beyond, and they're not responding and heading in the right direction, then I think it is reasonable to consider surgery. So I think from what I know for this patient, I would recommend surgery. I think more important than which arthroplasty should I have is really a careful decision. If this is just one simple disc herniation, then it's a relatively easy decision which level to treat. But we need to really look carefully and make sure that we're understanding exactly what's going on. Are there problems at the other levels? And make sure we're selecting the right level to do surgery. And then after that, trying to determine if there's something specific about this patient where one disc replacement would be better than the other. I think as long as we have the right level and the right decision made, there are multiple wonderful alternatives in terms of the implants that we can use to fix this problem.
This time we have a gentleman who has a C5-6 disc herniation. So that's a disc herniation between the 5th and 6th vertebra in the neck. So there's 7 vertebrae or bones in the neck. And in between the 5th and 6th one, he has a disc rupture. And he's had neck pain off and on since 2014. So we've got 7 years of symptoms. He's 32 years old and he's a golfer. In 2020, episodes started to happen more often. Pain's now going from the ear down to the shoulder when he turns his head side to side. He doesn't have pain with flexion extension. So his doctor told him a disc replacement is wonderful for avoiding pain in flexion extension, but since he doesn't have pain in flexion extension, but has it with rotation, he recommends a fusion.
It's critical for us to examine our patients carefully. I'm not sure I would make that kind of a blanket statement about flexion extension pain leading to one treatment, a replacement versus rotation, another. I do think that going back to your comments earlier, we want to understand if a person is having a lot of problems in the facet joints in the back of the neck. If the facets have a lot of pain or a lot of degeneration and arthritis, then that may be a reason that a disc replacement is not as predictable when it comes to improving the neck pain. So that's something that you make that decision based on looking at the scans and examining the patient, and also talking about the options. Based on what I've heard so far, the fact that it's been there for so long, definitely we want to make sure we understand how bad the bone spurs are, what kind of motion is left there. But assuming that there still is reasonable motion, it sounds like a disc replacement is certainly a consideration based on what I've heard right now. And particularly for me, when I'm taking care of someone who's very, very young, especially if I can take care of the current problem with the disc replacement, preserving the motion I want to, particularly because I do believe that also is protective and helpful for the health of the other discs down the road, which is important to all of us, but especially someone who's so young.
Frank, a 32-year-old golfer, 7-year progressive worsening symptoms. Does it have to be a fusion, or can it be an artificial disc if surgery is needed to treat him? And is flexion extension versus rotation an indication for which operation you would do?
Yeah, so first, just taking this patient out of the mix for a second, I agree with Chris that flexion extension and rotation makes very little sense to me. I mean, one of the most sensitive and specific provocative tests we have for a herniated disc pushing on the nerve is to have the patient rotate their neck over to that side to sort of temporarily irritate the nerve and reproduce their symptoms. So for me, most of my patients I do either operation on would have that test positive where they rotate to the side. So that for me doesn't point me to one operation versus the other. But I think the case presented raises an interesting question. Just to be clear, all the FDA studies that have been done, and then a lot of the clinical studies, the patients that we have disc replacements or fusions in those comparative studies present primarily with severe radiculopathy or that nerve pain down the arm. They all, or many of them, will have associated neck pain, which the study shows will improve. But their primary indication is a pinched nerve pain down the arm. I think it's a different patient to a patient like this one sounds like they might be, where they have really 95% just what we call axial neck pain. And I think that's a bit of a gray zone. There's not a lot of good studies. If patients come in and they say, I have neck pain, every time I move my neck, I have neck pain, I have very little or almost no pain down the arm, no numbness, no tingling, no weakness, it's just neck pain. That's a group where it's not as clear about the benefits, or not as well proven. So I sort of separate those out in my mind a little bit. I mean, I think in a way, if a patient has really, I'm convinced it's mostly neck pain for the reasons, Tom, you talked about, where the neck pain could be coming from the disc, it could be coming from the facets. I'm probably more inclined to fuse that level, although, you know, Chris pointed out, it's the last thing I want to do in a 30-year-old active, young, golfer, athletic patient. But I would just caution patients, you know, for pure neck pain, often you can do a lot of conservative treatment, and many times that'll help. And in that specific patient, disc replacement is less clearly defined.
Yeah, so I would agree with everything that both Chris and Frank said, that, you know, you have to be very specific about what it is you're treating, and really spend a lot of time evaluating the patient. It sounds like in this case, the patient has predominantly neck pain and didn't really complain a lot of arm symptoms. You know, when a patient has a pinched nerve, oftentimes it's very clear to us as surgeons, you know, what disc is involved before we even look at the MRI scan. So if the pain is radiating to the thumb, and the patient has biceps weakness, we know that's going to be a C6 nerve impingement. It's going to be a disc herniation at C5-6. The MRI scan confirms it. And that's a patient we know with 90% certainty those arm symptoms are going to go away if we take the pressure off the nerve. Neck pain can be a little more tricky to treat surgically. And so I would agree with Frank that that's a patient I'm going to make sure they've exhausted all their non-surgical options before considering surgery. And the other thing I will do in that instance is I will use injections to try to rule out where the pain is coming from. So that's a patient where I would send that patient for facet injections of cortisone into the facet joints. If that blocks the pain, that makes me think, well, maybe some pain is coming from the joints. Maybe there is some pain coming from the disc as well, but I need to think about the joints. If the patient doesn't respond to that, then I'm more likely to assume, depending on what the MRI scan shows, that that pain is coming from the disc. The other thing I want to look at is, are the joints painful because there's a lot of arthritis? In this case, it's a young patient, probably not a lot of arthritis in this patient. And in some cases, the facet joint pain will be relieved by just opening up the disc space and taking some pressure off those joints. So that's how I would approach this particular case.
I think it's important for patients to understand that just because we see an abnormality doesn't mean that it's necessarily causing the symptoms. And we have these very powerful diagnostic tests, especially MRIs, where we can look inside the body and see a lot of things that may represent a normal aging process and may not be symptomatic. And so that's, I think, what the summation of what we're hearing is, yes, get the studies, look at them, but they have to correlate to the problem, and we have to make sure the treatment we're offering is a solution. But I would think that it's fair to state that just because you have pain on rotation versus flexion extension is not an indication for artificial disc versus fusion, and that it all has to be individualized. So as we're coming to a close of this session, which has been fascinating, I'd like to give all of our panelists a chance just to give some final word of advice to patients regarding spinal health, regarding disc replacements, any thoughts they have. So for closing, Frank, I'll give you the first word.
Yeah, so as you've heard on this webinar, I think all of us are enthusiastic about disc replacement. I said it earlier, and I think cervical disc replacement is probably the best studied procedure we have in spinal surgery. And we have very good data that confirm outstanding results in the right patient and carefully selected patients. So I think there should be a level of comfort if you're seeing a surgeon who's experienced, who has a robust cervical disc experience, disc practice, and you have symptoms that sort of fit the picture we've talked about today. You can be very comfortable. You can go ahead with the surgery with a 90% plus success rate, an incredibly low rate of complications reported, and a very quick recovery, resumption of normal activities, including getting back to all the things you enjoy, golf, sports, running. So I think it's an operation in the right patient that we can confidently predict very good outcomes if you have the right surgeon and the right indications.
I would agree with everything Frank said. I think it's important that patients know what their diagnosis is and get plenty of information about their treatment options, that they make sure that they have considered all treatment options before considering surgery. We always tell our patients, surgery should be a last resort unless there's a significant weakness or neurological issue. We try to put that surgery off as long as we can. But in those cases where the patients have not responded to non-surgical treatment and they're in significant pain, cervical disc replacement is a very good option for many patients. And it's something that it's worth investigating and researching as a patient.
So I think my closing message for people who've been dealing with neck and arm problems would really be one of hope. We have great options to help. It is best to do your research, keep trying things to find what works, and find the right person to help you through it.
I would like to thank all our panelists for their excellent input. This has been a fascinating conversation. Hopefully, for those of you who have neck problems, you're finding some possible solutions. We're excited at Spine Talks, the National Spine Health Foundation, to bring you unparalleled access to the best experts in the world. Thank you. As the chairman of the Medical and Scientific Board of the National Spine Health Foundation, our mission is to educate Americans as to help to improve their health and to overcome spinal problems. We'd like to thank the corporate sponsors who, through an educational grant, have allowed us to present this information to you. Thank you to Medtronic Corporation, Zimmer Biomet, NuVasive, Sentinel Spine, and Orthofix.